We're tired of being villainized one minute and being the hero the next. We're tired of being mistreated. We're tired of not being able to work to the level that we want to deliver the patient care that they deserve, that our patients deserve. They deserve so much more than what the hospitals are giving and are allowing to happen.
It's important to be part of a union because you have to have a voice.
Welcome to Union Talk. I'm Randi Weingarten.
As we wind down the year, it's always important every year as we get to December and January, we take a mental and a physical break. We think about the holidays and the family gatherings. And, we try to have hope for the next year. And this year is no different than that, with one major exception. Our brothers and sisters in the medical field have not had a break at all. Whether it was COVID or the shortages in the aftermath of COVID, or this winter season of COVID and RSV and the flu, or the workplace violence, or just the stress and strain of being the ones who have held all of us up. That's what our nurses and healthcare practitioners have done for all of us this past year, and the year before that, and the year before that. And they do it in a healthcare system that is increasingly broken and increasingly too expensive. And so we end the year wanting to talk to incredible guests who actually live these healthcare issues every day to help us better understand and navigate and find solutions, but also to be able to say thank you. So the people who are with me today are David Keepnews, who's the Executive Director of the Washington State Nurses Association, January Belcher, who is a Med-Surg board-certified registered nurse at The Ohio State University Wexner Medical Center, and Howard Sandau, a surgical intensive care unit registered nurse at NYU Langone Hospital. And before I ask them a whole bunch of questions ranging from shortages to staffing to what do we need to do in the healthcare industry to keep healthcare personnel at the bedside and help all of us who rely on them, let me just set this table for a minute. For nearly 3 years, our nation's healthcare professionals have worked through these unprecedented challenges. The COVID pandemic only made worse what millions in the field were already saying. They were already exhausted. They were already burnt out. They were already emotionally drained. And when we polled our own members, we are the fastest growing nurse union in the United States. In February 2022, 23% of our healthcare workers, nearly 1 in 4, said they were likely to leave the healthcare field soon. This great resignation comes as the nation's population ages and grows and becomes more diverse. So instead of having fewer healthcare workers, we actually need more people at the bedside. And anyone who's been at a hospital anytime in the last few months knows this and sees it. But what's happening because of the stress and strain is that there's such a shortage that employers in healthcare are only able to hire at the same rate as workers leave. That means we got more and more and more shortages who are now filled more and more and more by transitional workers, sometimes, as the healthcare folks would tell you, called travelers. So, it's fantastic that people all across America, including our bosses, lauded healthcare workers as healthcare heroes for their efforts during COVID, they deserve that and much, much more. But the way in which you really respect people is to deal with the fact that they're underpaid, overworked, and stressed out. And we need to solve the root of those problems, which is why the AFT convened a healthcare staffing shortage task force, which really listened to our AFT state and local leaders as well as frontline healthcare workers. And the task force was charged with examining the state of what was going on, but also what things policymakers and employers and unions could do right now, short term and long term, to ensure that hospitals and healthcare facilities are appropriately staffed to provide high quality care to all. And not just appropriately staffed to provide high quality care of all, but to ensure that these hospitals are safe, or that other places in which our nurses and healthcare workers work are safe. So the findings were released last month, and it's important to recognize not only these findings, but to actually act on them. Yes, of course, it includes better compensation, but it also focuses on workplace conditions, dealing with increased workloads, dealing with safety, and making sure that these essential workers have a seat at the table when it comes to workplace decisions. So I really want to hear from January, David, and Howard in terms of these questions and what they think. So David, why don't I throw the first question to you about, when we hear the stories of workplace violence or violence in hospitals, we are compelled to act. But frankly, you are ground zero for this right now, given the tragedy that and the murder of a visiting nurse who was, in the Washington State Nurses Fraternity.
Well, thanks, Randy. Workplace violence is a daily problem and a daily issue for nurses and other healthcare workers. When we think about that, we usually don't think of such an extreme and tragic example as what happened to our member and our colleague, Doug Brandt, who was a highly experienced home health nurse, was working for a home health care agency in Spokane, Washington, on the east side of the state, was doing an initial home visit to a patient recovering from stroke. And during that visit, the patient's adult grandson shot him 3 times with no provocation. Doug staggered to the floor, and then the grandson came over and shot him again, and then fled and was caught by police the following day. And, there's a number of levels on which I know we've reacted and others react. One is just to be stunned that this could happen. Doug was, I didn't know him personally, but from everyone that I've heard from, he was well loved, well respected, just really just a great exemplar of what a nurse and what a home health nurse should do and should be. So I think certainly his colleagues, his coworkers, his patients have been stunned by this. So obviously there's a need to respond on that human level, to offer support, to recognize that tragedy. But then there's also a need to really refocus and redouble our efforts to address this problem so that we can do whatever we can to prevent this kind of tragedy from happening again, and to prevent workplace violence in general, and to minimize the risk that healthcare workers, nurses, and others put themselves at. So, in Washington State, we have a pretty good law on workplace violence prevention. that really focuses on having a plan, having a committee that can look at this. One of the problems is that law is not consistently implemented, not consistently followed. We don't have the national guidance or national standard that we need in terms of OSHA having a clear workplace violence prevention standard. So, there are the circumstances of this particular tragedy that obviously we need to focus on because it's affecting so many people right now. But we really need to look also at the broader issue of just the everyday problem of workplace violence. And as I said, redoubling our efforts, making it clear that the employer, first and foremost, has a responsibility to do everything possible to keep nurses protected, and and to approach this again from a broader viewpoint of all resources possible being put in to prevent this kind of tragedy and the everyday tragedy of nurses who are whether threatened, assaulted, injured. None of this should happen to any nurse or any healthcare worker.
So, look, this is truly a tragedy that's happened. And I know from my own experience that working in a hospital, particularly post pandemic, and as a result of the pandemic, we are seeing workplace violence. We are seeing patient family members attack the nurses, verbally abuse them. It's like we've become the enemy in healthcare for some reason, which, I have a difficult time wrapping my head around, that we have become almost like the enemy. I know the struggles that we have, even though we have, a committee and we have policy and procedure in place. A lot of times, for some reason, there are, when somebody experiences this type of violence or abuse in the workplace, that somehow, it has to stay within the workplace and no one can know about it. And I think that's because, you're protecting the brand name at the expense of employees. And I think that is really, really an unfortunate scenario. With our members in New York, we have a state law that makes it a felony to assault a nurse in the workplace. And as a member of the Federation of Nurses, we take workplace violence seriously. Anytime we hear about it, we encourage the nurses to pick up the phone and call the police to the hospital and arrest the patient. So that's the advocacy we do amongst our members. And we've successfully prosecuted individuals who assaulted nurses in the workplace and who are currently serving prison sentences because of it. So I think it's a combination of a lot of different things, encouraging our members to being a punching bag is not part of professional nursing practice, and enough is enough. And don't be afraid. Be empowered by your union brothers and sisters to prosecute people who abuse you, attack you in any way, shape, or form.
Thank you. January?
Just a few weeks ago, I witnessed a coworker being beat violently on our unit. It was by the grace of God that I got that patient off of her while he was yelling profanities and saying that he was going to kill her. What do you do with that? She was traumatized, and everybody that witnessed that was traumatized because we believed he was trying to kill her. And then you run that fine line with mental health, and we want to protect our mental health patients, but how far do we go doing that and making sure the staff member is safe as well? If you're not going to have trained professionals on the unit where we can act differently when it is involving mental health, where we can get meds and security on our unit and all that stuff in a rapid fashion, then they don't need to be on our unit. You're mixing violent patients with more sick, acutely sick patients. We're like, the doors don't lock. So anything can happen. So how do you protect yourself? How do you protect other patients? What do you do with that? And it's not like we can, again, call the police, because, we also have a, a law too about it being a felony. But again, what can you do when it's a patient that has mental health issues, and that patient is still on our unit, and they're expecting co-work or staff that witnessed it, the one that was actually the victim, to still be there. And it's like a slap in the face. And it's not enough to just transfer somebody out off the unit, because now you're putting a whole group of other people at risk too. So, we spoke with OSU, and we're like, why not create a unit specifically for that, where you have, all the protection that you need, as far as having security right on hand, reaching out to other facilities like Twin Valley, who deal with violent mental health patients, and learning their ways and their methods, and just keeping them on a particular unit when they're not appropriate for other med surge floors, or even our Harding mental health. I mean, we have to do something more. The public and private sector works a little bit different. So us being public, we don't have the option of turning away people, whether they're have the capacity or not. It's all about customer service, and how far are you willing to have that customer service go at our expense of being injured? I have a torn knee ligament because I was assaulted by a patient. And then there's no recourse, there's no standard for stopping the abuse. Every single day, there is a staff member being verbally abused or physically abused at our facility. Every single day.
So this is important. So when anybody who's listening to the podcast, when people hear the AFT fighting for this kind of OSHA standard and fighting for it to be in the law, and asking, all of us, any one of our listeners, whether you're independent, Republican, or Democrat, conservative, liberal, to support us on this, it's because we want to keep people who know that they're in, tough circumstances, because they're dealing with patients all the time who may have all sorts of emotional struggles, or their families have emotional struggles. We want to make sure that people in healthcare are safe and are treated safely. So, we need the support of the public as we keep fighting for this standard. And last year we got pretty close in the Senate. I mean, we got it past the House of Representatives, and we got pretty close in the Senate. And this year, as the House of Representatives change hands, all we need Republican votes as well as Democratic votes to get this over the top. And you just heard, to all our listeners, you really heard why these people, the folks we represent, are in hospitals or are in these settings all the time and are helping everyone get well. Our job is to make sure that they're safe. So let me go to the other kind of components of why we have such a shortage in healthcare staffing, so that we, break it down for our listeners.
There's not enough staff. For instance, I work in a critical care environment where it should be a 2-to-1 ratio. There's a very specific reason why it should be a 2-to-1 ratio, because you're monitoring hemodynamics, your blood pressure, your heart rate, your respiratory rate. If you're on a breathing machine, somebody has to make sure that the machine is functioning at all times optimally, that you're oxygenating properly. If you go in for a surgery and you have a vascular surgery, you need a nurse to be able to do vascular checks on your extremity, where you just had a very comprehensive surgery to return blood flow to your extremity. So that requires a nurse to check your blood flow could be every 15 minutes for the first couple hours. If you've had a stroke and you're on a medication, a clot buster, to try to resolve your stroke, you need a nurse who's doing neuro checks on you frequently to make sure that you don't throw another clot into your brain, or that you don't have a bleed inside of your brain. And that requires close monitoring. So if, in fact, you don't have enough nurses and you have a 3-to-1 ratio and maybe a 4-to-1 ratio, how is it possible to do Q15-minute checks on 3 patients at the same time, or 2 patients at the same time, and then your third patient is a level 1 trauma patient that needs to have massive amounts of blood transfused? So one patient is going to suffer because you can't possibly be in 3 rooms at the same time. So let's, for instance, if my trauma patient is bleeding to death and I'm trying to resuscitate with blood, yet my other patient, who I'm supposed to be watching the vascular checks for blood flow in the leg, I don't get over there and I don't notice that the blood flow has stopped, the leg is turning blue. And what is going to be the end result? Unfortunately, the person with the vascular issue is going to end up losing their leg, and it's going to affect their life for the rest of their life, because they're going to end up losing their leg. And that's the consequences of not having enough nurses in a critical care environment. Now, I can use examples on a med-surg floor. There's a tremendous amount of falls in the hospitals. Now, this is a dirty little secret that people don't talk about, but we are having so many falls. People are falling in the workplace. The patients are falling, getting injured. And the reason this is happening is because the ratios are so stretched that you can't possibly have your eyes on every single patient. And, patients are compulsive, particularly men. Men like to stand up to use the bathroom. So if nobody's answering the call bell, they're going to compulsively get out of the bed, try to urinate, and they're going to fall, or walk to the bathroom and fall. Or they're on medications that, for blood pressure, and they take the blood pressure medicine, then the blood pressure drops, then the patient doesn't realize they're dizzy or lightheaded until they get up to stand to go to the bathroom, because there's nobody there to help them or assist them. So falls are a result of not having enough staff. And those are just, some examples of, possibility of patient injury. But we also have a whole other cascade of problems, and that has to do with a nurse's just physical well-being. It's just impossible to be on your feet for 12 hours, to not be able to use the bathroom, to not be able to eat, not be able to refresh your mind so you can think clearly and use critical thinking skills when you're trying to care for patients. And those are things that happen when you don't have enough staff to care for the patients. Those are just some examples. And the other part of it is not just nurses, but ancillary staff. So if you don't have enough ancillary staff, and that could be for a number of reasons, where maybe the hospital system doesn't hire enough, maybe that the candidates that are being hired have some type of background issues that they can't be hired, or the ancillary staff are assigned one-to-one nursing sitter for patients who are either compulsive, combative, or pulling out, lines, IVs. So they have to have somebody sit there. So if the nurse's aide is sitting there with one patient, the other 30 patients they're assigned to don't have that support. So it's really a no-win situation. And it really boils down to, I have a number of theories as also an adjunct faculty member, issues with higher education and having, nurses with advanced degrees making, far less than somebody who works in a hospital, which is the reason why our advanced practice nurses are not going into education. And because we don't have enough faculty, we can't admit enough students into nursing programs. So it's a massive cascade of problems. And I think, we have to really figure out, what exactly we're doing so we can, resuscitate the profession of nursing, because right now we're on life support.
Mhm. So I think you, in a very graphic way, helped the non-medical professionals, including myself. We could see you created a picture for why that staffing is so important and so imperative. And what I would like to do is take the rest of our time, because this report talked about a lot of solutions, and I think you touched about on some of them. But so one of the so it's working conditions, it's the a recruitment crisis, it's a retention crisis, and so why don't we take and obviously it's profits over people. So why don't we, I'm going to ask January, I'm going to ask you to decide which of those things you want to take on, recruitment, retention, working conditions, compensation. Which of the solutions do you want to take on?
I guess compensation. I mean, so much of it is just really rolled into everything. Um, you're wanting nurses to do a lot more work than what they're getting paid for. When you have a shortage of your nurse aides, respiratory therapists, physical therapists, dietary support, when you have a shortage in every other area, that comes down to nursing filling that brunt. We are the only occupation that can literally do everybody else's job, but no one can do our job. And when you're being stretched thin, and on top of that, you're being forced to work over your amount of hours that you even signed up for, and then you have the verbal abuse on top of that, and then you're short staffed along with other nurses, it just weighs on you. It's so ironic. Somebody posted on social media, you know, when you're closing the eyes of a person, when you're helping a family member deal with death, when you are opening eyes to give life to a baby, when you're saving lives, giving CPR, crushing bones, when you're able to do all those things, then that's when you should be able to speak on our salaries. When you're doing all those things, and you're also taking on the jobs of other people for whatever reasons why you're not hiring them, and you're putting that on our shoulders, and you're giving us more time and more work even outside of that, and then it's telling us that we're still not doing a good job, or there's still more to be done, and then criticizing us if there's a fall happening and when we're grossly outnumbered, and you have unstable patients that you're taking care of. What do you want us to do? If you want people there, then compensate for what they're doing. If you want people there, lighten the load and the burdens of student loan debts, and also offer more things to manage those stressors in life. You want to give us pizza parties. I did that for my kids when they were in elementary school for their class for honor roll. I don't need a pizza party. I'm a grown woman. We are grown men and women. We don't need pizza parties. We need something that is going to help us with our everyday life and our everyday balance. You know what? How about you include in our insurance plans that we get free massages and going to the chiropractor, or health gym memberships for free. Do stuff that's going to pour back into us so we can pour out into others. Give us an opportunity to live life and not struggle and live paycheck to paycheck. Um, allow our ancillary staff to have a decent working wage as well. They are crucial in saving lives as well. It doesn't make sense, and no disrespect to anybody or any other profession, but it doesn't make sense that fast food workers are making more than our nurse aides who are critical in helping us save patients' lives. So you want people there, but you don't want to pay for people to get there. It's challenging to get into nursing school. So that's a whole different issue, but it's also expensive. Teaching, teachers and nurses have a intertwined profession. They're so much alike, and we're struggling all around. So why not have programs in place where people might go if they don't have that brunt of tuition to pay for?
You raised the whole issue of student debt a couple of times. So what if student debt was forgiven for nursing schools? Do you think that would help in terms of recruitment?
I think that would open up so many doors and pique people's interest, because again, you're also reaching out to a population that may be disadvantaged, who has the education but doesn't have the resources to get there. So you're opening up the doors to different minority sets, to have representation, and allow those doors to open to help our crisis. That absolutely, positively would help us.
Great.
100%.
So, David, I saw you shaking your head on all of the recruitment issues and compensation issues. I want you to weigh in here.
Well, and in terms of addressing, having enough nurses working, I think. Well, first of all, I think I've heard some really good points in terms of recruitment, and certainly the financial aspect of that is important. We know that the cost and the prospect of a huge debt burden keep a lot of people from applying, and that particularly disadvantages people from poorer backgrounds. That includes many, obviously not all, but people of color. So, trying to have a more diverse workforce, I mean, that's an issue there too. In terms of retention, I think compensation clearly is a key part of that. And I'm glad that in Washington State, we've had some recent significant wins in terms of new contracts that pay nurses much more fairly, and that includes some fairly substantial increases. I think that's part of the picture. It's part of the puzzle. By itself, it won't be enough. I know you asked that we not get into too much detail on staffing, but I think that's part of it. I think the overall stress and of having nurses being required to do more and more with fewer and fewer resources, including human resources, it adds up to making it to driving nurses away from the bedside, often driving them out of the profession. For many, people have turned, at least temporarily, to travel nursing. In large part, yes, because it pays much better. Sometimes you've got people making 3 and 4 times as much as the core staff they're working next to. But you'll also hear nurses say, I don't have to be involved in the politics. I don't have to be involved in the conflicts that happen. I can just go do my job, take care of my patients, and collect a paycheck. I mean, we want people to feel an investment in where they're working. But for that to happen, the employer needs to have an investment in their workforce and be willing to invest in nursing and invest in other healthcare providers. That sense of a lack of commitment from the employer and that lack of respect is really one of the key problems in terms of keeping nurses working. And so, I mean, I think there's a lot of components, but I think it really adds up to a sense of treating people with a sense of respect, a sense of fairness, compensating them appropriately, and working in decent working conditions, including good staffing.
What about strengthening some of these career tech ed programs that we should have maybe in high school? I mean, I taught at Claiborne High School for the health profession, so we had an LPN program. But what if we had more of these programs so that, kids could get a head start in high school for going into some of the nurse programs or apprenticeship nurse programs? Would this help?
Yeah. So look, I agree that we have to start early. We have to be in the high schools. We have to advocate for CLE programs that lead students to health related professions, and support them. There's no question that, in my mind, that there are enough candidates that want to come into professional nursing practice. They're turning away up to 80,000 people a year because they don't have the spots for in these nursing programs, and that leads.
Wait! Did you just say 80,000 people a year are turned away from being nurses because we don't have the spots in education to educate them? Did you just say that?
I just said that.
All right, I just wanted to make sure I heard you right.
It's not that people don't want to become professional nurses. It's just that it's very difficult. And this difficulty arises because there are not enough faculty members to teach the nurses. So you can have the exact same advanced degree. You can be a faculty member, make 78,000. You can work in a hospital and make 110,000. They don't call them nurse faculty in the hospital. They call them professional development specialists, doing the same work, but making dramatically different amounts of money, right? So that's why we have such difficulty getting advanced degree nurses to go into these faculty positions, because you just can't survive on that type of salary. And why would you work for $30,000 less when you could work in a hospital and make more money? I know it's not all about money, but that's a big driver of everybody's livelihood. So I think a couple of things that I would recommend is, one, that we support these CLE programs early in high school healthcare career development. I think we should focus on making some type of monetary equivalency for advanced practice nurses, whether you're teaching in a nursing program or you have the same role inside a hospital. There's got to be some equivalency there. That's very, very important. So the third thing I want to say is that until we are able nationally to change the way nursing is reimbursed. Right now, the hospital gets a flat charge for Medicare, Medicaid for hospital services. Until we can put some monetary value on the profession of nursing practice, where the hospitals get reimbursed for specific nursing services, I think we're just in a no-win situation, particularly when it comes to salary and compensation. Because believe me, if the insurance companies were paying for nursing services and reimbursing for the services that we do, salaries would go up, in my opinion.
So clearly, we're not going to get this because it's needed. So this is kind of where the power of the union comes in. And David talked a little bit about this before with what, in terms of what was going on in the fight for safe staffing in Washington State. And I want him to talk about that a bit. But I want Howard, because we got breaking news here. the UFT nurses and healthcare practitioners just won UFT in New York City, a very big arbitration in terms of really addressing state staffing. And we're trying to get to this through legislation, through arbitration, through standards, through all sorts of other things, collective bargaining. But Howard, why don't you just talk a little bit about what happened in terms of the UFT in New York City?
Sure. So we recently had a massive arbitration victory in reference to staffing. So in our collective bargaining agreement, we have staffing ratios, staffing guidelines in the hospital. So the hospital routinely violates the staffing guidelines because there's no punishment for it, right? So the nurses were filling out staffing incident reports, and I'm not talking about one or two, I'm talking about thousands. We're talking about thousands of grievances. Hospitals sustaining the grievances, but then not doing anything to rectify the staffing issues. So we made a collective decision that no matter what the hospital said at the various steps of the grievance process, that we were going to push every single grievance to arbitration. And that's exactly what we did. And when we got before the arbitrator, we made some arguments about that the staffing guidelines are contractual. The hospital has an obligation to respect the contract. But also we made arguments that there's got to be some type of remedy for the nurses when they're working short-staffed. So the arbitrator broke it into two pieces. He first sustained our arbitration about the staffing guidelines being violated by the employer. He said that those guidelines in the contract are contractual, and the hospital must meet the contractual guidelines. The second piece of it is that he ruled that there's got to be some remedy, and the way we convinced him was that we basically broke it down to dollars and cents. If you have 4 nurses or 5 nurses, and the hospital is paying the salary of 5 nurses to work a shift, and 2 of those nurses are not there and they're not replaced, you have 3 nurses who are doing the work of 5 nurses, 3 nurses being paid to do the work of 5 nurses. Well, who's being paid? What about the salary for the nurses who are not present? So he ordered us to get into a mediation, which we did. And through a long series of mediation and going back to the arbitrator ordered the hospital to pay $138,000 in compensation to the nurses who worked on those short-staffed shifts. So this basically has opened the glass ceiling. We are pursuing all of our staffing incident reports straight to arbitration. We've now set up an arbitration panel of 3 arbitrators, including the arbitrator who ruled it this way for us. And we're now getting ready in January to start. We get 3 sessions of mediation to resolve pending arbitrations, which there are another 6. And if there's no financial remedy, then we will go before the same arbitrator and he'll rule financial remedy. So this is something that's not been done that we're aware of anywhere in the United States. And we are just so happy and thrilled that, we're finally being heard and that we're being compensated for this tremendous amount of workload that's being caused by, hospitals not adhering to collectively bargained, negotiated ratios.
And that is the power of the union and the power of being able to have a union contract that had that arbitration clause that you could then use.
Yes.
David, you have a different approach, but a really important approach in terms of staffing in Washington State. So you want to go through that approach?
What we have in Washington State is passed a law several years ago that provides for staffing committees of both staff nurse and management that come up with staffing plans for each unit on each shift. It was, I think, in concept, very sensible. Allows a focused approach on what the needs are on each unit. The problem is, again, with the actual enforcement of that. The law has a number of loopholes. The hospital CEO can veto the plan. It also allows for exceptions during unforeseen emergencies, which the COVID pandemic, even now, is considered, as many years as we are into it, an unforeseen emergency. So basically, the Department of Health has no enforcement authority, will not investigate complaints. So what we, and working with other unions, introduced earlier this year in the legislative session, was the idea of maintaining that mechanism of staffing committees and staffing plans. First of all, putting more teeth into them, making them more enforceable, getting rid of those loopholes, increasing the penalties, but also having minimum staffing standards, aka ratios, but basically working in conjunction. So you would have a minimum staffing level, and it was differentiated by type of unit, but that every hospital would have to comply with at least staffing at that minimum. And then you would look at adjusting that based on the specific conditions in each unit, et cetera. So really taking two different approaches that have been used in different states. California, of course, right now being the only state that has mandatory ratios for all units in the hospital. But really combining those two, and to us, it made a lot of sense. It gives you a floor, but it also has a means to adjust above that floor. We had incredible support from nurses throughout the state who were very vocal in making themselves heard. The law went through our state House of Representatives, through several committees there, through the Health Committee in our Senate, and then stalled in the Fiscal Committee, the Ways and Means Committee. But it got pretty far. And we've been working now to look at what strategies we will take in terms of legislation. And possibly we're looking at the possibility of, if we are stalled again in the legislature, of taking this to the people, taking it for a popular vote to be put on the ballot. We actually have found, we did public polling and surveying when we introduced this past session. There was a lot of feeling of, well, this might be popular this year because of the pandemic. This might be the only opportunity. We just finished polling again for where the public, a sample was at, found support was even higher than it had been before.
Yeah.
I think the public gets it. And the public gets that it's not just during the pandemic. It didn't start with the pandemic. It's not ending with the pandemic. But this is a systemic long-term problem that needs real solutions with teeth to ensure safe care for patients.
It is. And, this is where the union becomes part and parcel of being the accountability and the transparency for safe care, because our working conditions are patients' health conditions.
Exactly.
As Howard so eloquently talked about earlier in the podcast, about what happens if you're in the intensive care unit and you have 3 patients when you really should only have 1, not even 2. So I'm going to ask January, I'm going to ask you a really unfair question to end with, which is, you are an incredible nurse and an incredible activist in Ohio. What keeps you going? How do you still have hope?
That's a great question. I'm a part of Ohio State University's nursing organization. And I just recently was added on to being a board member. And I've been a nurse for 20 years. But here in these last few years, the nursing career has taken on a whole different outlook for me being a part of the union. Advocating for my fellow brothers and sisters has put on a new life in me to see things better for all of us. To advocate for the marginalized, to advocate for the new nurses, those that been there forever, and since the devil was a doll baby, all of us, and all of us coming together, especially during our contract negotiations. It was so beautiful to see, and we have one of the most successful contracts in Ohio, where we secured safe staffing ratios that unfortunately the employer is not adhering to. So we need to take note from New York. But we secure safe staffing ratios. We phased out mandation completely. So you couldn't just overwork us and not be accountable for that. We secured, if you want us to work over, you're going to have to pay us for it. And then also getting our wages better than what they've been in a long time. So what's kept me going is definitely the outcomes, but just seeing the nurses and just allied healthcare professionals coming together and just saying enough is enough. We're tired of it. We're tired of being, villainized one minute and being the hero the next. We're tired of being mistreated. We're tired of not being able to work to the level that we want to deliver the patient care that they deserve, that our patients deserve. They deserve so much more than what the hospitals are giving and are allowing to happen. They're phasing out med surg and now putting it as acute care because now people are more sick. It's not the little, cuts and scrapes. We are dealing with mental health issues and some very serious disease processes. COVID exacerbated it, but they were all already there. People are just so they're sick now, and it comes through sedentary lifestyles. It comes through our environment, lack of resources. It's a whole combination of things, but it's not what it used to be when I started earlier. It has gotten a lot more tragic, a lot more intense on every level. So what used to be our typical easy breezy med surg is no longer that. We're a level 1 trauma hospital. We're a level 3 maternity unit. So, we're getting the sickest of the sick coming through, and we're shutting our doors because we can't take anymore. So that leaves it to the other hospitals to take on those brunts, and even the smaller ones. So everywhere across the board, they're more acutely ill, and the staffing ratios are terrible. And just that fight and wanting to see a change, knowing that it is possible. Ohio State made $6.6 billion in profit. They're building a $2.2 billion addition to the hospital.
Did you just say 6.6 billion?
I said billion.
Yeah, with a B.
Billion. B, with a B. And they have added on an addition of $2.2 billion hospital addition. It does not affect their bottom line of that 6.6 billion. So please don't tell me we don't have the money to retain nurses and allied healthcare professionals. Please don't tell me we don't have the means to raise people's pay wages to make it a sustainable way of living. We're also a university hospital. Please don't tell us there's not a means to sit there and entice people to come to our profession with a less of a burden to bear on tuition. There's so many things that can be done, that should be done. And again, it's not political. It is a human interest situation. And if we're pouring out all this money as a government to military and all that good stuff, to defense, we can cycle some of that money to come back to the people.
Exactly.
Our government is to work for us. We are here for that, and we're not here to protect the corporations and the billionaires. You know, they're living well. Believe me, if they can't get that 10th airplane or that 15th mansion, oh my gosh, I'm so sorry. But it's time to start working for the people. And just seeing my coworkers pour into me and pour into my fellow board members of our union, it gives you hope.
So you get hope from the work that you do for and with your members.
Absolutely.
As we end here, what you're seeing in a situation where there's really a lot of stress and strain and problems, healthcare is absolutely necessary for all of us and all of our families. And David and Howard and January are doing the hard work of fighting for the respect and dignity for our nurses and our other healthcare providers so that they can be on the job, stay on the job, not be, more stressed and strained than the job would ordinarily entail without all of the other stuff that we've had to deal with, violence and mandatory overtime and COVID and so many other issues, including, a healthcare industry that's broken. But what you've heard here is lots of very tangible solutions that if you have a union that is working together on behalf of the nurses we represent, the healthcare workers we represent, as well as the patients we serve, we can not only come up with the solutions as we have in our new report, which is at aft.org/HC shortage, and it's simply called Healthcare Staffing Shortage Task Force Report. So you can find it pretty quickly at aft.org/healthcare shortage. So there's a lot of solutions there, but what you've heard here is things that we can do together as a union, be it contract negotiations in all of these three jurisdictions, Ohio, Washington, New York City, the enforcement of those contracts like you just saw in New York City, the advocacy that is leading to either state legislation or maybe a ballot referendum that we're going to see in Washington State, the national advocacy that we're going to do, we have done, and we will continue to do on getting a violence standard, and the day-to-day work that January just talked about in terms of what's going on in Ohio, in Columbus, at the Ohio Medical Center. This is what a union does to protect our workers and to serve our communities. But I just want to say to my three guests today, January, Howard, and David, what you're doing is God's work, righteous work. It's just incredible because nurses are really on the front line, not only of this pandemic, but of the mental health crisis and the healthcare crisis. And they're just really holding everything together, nurses and other healthcare providers, for all of us. And you, every single day, are serving them in your union roles. And I just am really, really, really grateful. And I just wish you and your families, as well as all of our members, the happiest and healthiest of New Year's. Thank you.
Thank you.
Thank you, Randy.
I hope you enjoyed this episode of Union Talk. Remember to subscribe wherever you listen to your podcast and tune in every other week for a new episode. Thank you, be safe, and be well.